on to the last lecture of this session that features Professor Galal Eldin Najib El Kilany. He is currently a senior consultant cardiologist at the Giba Hospital in Fujairah, United Arab Emirates. He also happens to be the professor of cardiology at the Tanta University Medical School from Tanta in Egypt. Professor Kilany this morning joins us for the next 12 minutes to speak on diabetes-induced cardiomyopathy, early prediction and intervention, following which we will have questions.
Thank you, Mr. Chairman. Bismillah ar-Rahman ar-Rahim. My dear colleagues, my professors, it's a great pleasure for me to be here in India for the first time, and I should send my greetings for the great success of the Congress to Professor Chopra and the Executive Organizing Committee who invited me and my colleagues. Actually, the most impressive thing here in India that you feel that you are at home. The hospitality is very nice. You feel that Indian people are very kind, and I feel from the first minute that I am at home. Actually, I published this presentation, the diabetes-induced cardiomyopathy, in the British Journal of Medical and Health Science, one year and a few months back. My concern here, diabetes cardiomyopathy is a distinct primary disease process. It is independent of coronary artery disease, which leads to heart failure among diabetics. We know all that diabetes influences the myocardium mainly through the incidence of macro and microangiopathy, metabolic disturbances, and the cardiac autonomic neuropathy. But early myocardial fibrosis and thickness can be now early diagnosed to stop the progress of this serious disease to dilated cardiomyopathy. So diabetic cardiomyopathy is a distinct primary disease process independent of coronary artery disease, which leads to heart failure among diabetics. And all the epidemiological and clinical trials data have confirmed the greater incidence and prevalence of heart failure among diabetics. Robler, he is the first one to term diabetic cardiomyopathy after performing the post-mortem studies in diabetic patients, and he excluded the coronary artery disease and hypertension and structural heart disease as the possible etiologies. So how to early predict cardiomyopathy among diabetics? First of all, diastolic dysfunction in the most studies, there is the early sign of diabetic cardiomyopathy and preceding the systolic damage and clinical signs of heart failure. And currently, a detailed novel echocardiographic examination and measurements of the N-terminal pro-B-type natriuretic peptide provide a sensitive method that identify early signs of myocardial dysfunction. This is a very interesting case. 6-year-old male and patient known with diabetes, followed by hypertension and dyslipidemia with long history of progressive dyspnea. The first presentation in the tissue Doppler have been found to be an impaired early annular velocity here less than 5 centimeters per second, with normal heart at that time, only diastolic dysfunction is the first abnormality seen. And after that, on the follow-up, he developed this severe diastolic dysfunction pattern with dilated heart, and here the tissue Doppler to assess the E-annular velocity. But now, speckle tracking echo and the twist and untwist, as presented yesterday, the heart is squeezing upon itself, like Dr. Nanda presented yesterday, and you can diagnose the abnormality in the longitudinal function as well as the circumferential fibers, which is a very sensitive method to detect an early onset of dysfunction before the abnormality in the pulsed wave Doppler and even other parameters. Here now we are doing a great work now with some of the companies to do like a diastolic strain as well as a systolic strain, which have been presented before. Here is a study which I published in Germany a few years back that the longitudinal fibers here can show the early effect of abnormalities even if the systolic function is normal. Just you are tracing the endocardium here and you can get the acoustic markers, and any abnormalities in the subendocardium, which is particularly susceptible to effect of fibrosis, ischemia, and hypertrophy, can be detected in this bull's eye, which is a quantitative technique. This is an area of reduced shortening in comparison to this red zone, which is looking to be normal. This can appear very early among hypertensive diabetic patients with early diastolic dysfunction. This is another thing that you can see. If you want to compare the automated function imaging or the global strain, you can compare it with the three-dimensional echo. You find a very good correlation. So 3D echo can be used to assess these patients. We found that the depressed value of global longitudinal peak systolic strain in apparently normal contracting heart with a normal ejection fraction are highly suggestive of subtle left ventricular systolic dysfunction and was correlated significantly with the degree of hypertrophy and the impaired left ventricular compliance. So you can assess now and can use the strain, 2D strain and 3D strain to assess quantitatively the area of either necrosis or fibrosis, the area of reduced contractility and the normal myocardium. You can use like a nuclear study nowadays. Systolic dysfunction, advanced tissue Doppler imaging, which is an important risk factor among diabetics, allow the measurements of sensitive indices of regional and long axis function, both in the left and right ventricle. So even if the ejection fraction is normal, you can, in the presence especially of mitral incompetence, so you can assess the rate of pressure development dP over dt, which is depressed in this patient in spite of normal ejection fraction, and also the global strain is depressed -13 among those patients with, who have diastolic dysfunction. Recently, a 4D echocardiography can be used, and we can trace the myocardium in a 4-chamber, 2-chamber view, 3-chamber view, and then we can get the 4D strain, and we can assess any regional abnormality objectively and quantitatively very easily. So the diagnostic method, Mr. Chairman and my dear colleagues, is echocardiography, cardiac MRI, and cardiac biomarkers. And this diagnostic method is now highly advanced by use of new technology, and you can assess either abnormality whether in the longitudinal function or the longitudinal axis with the heart or the circumferential fibers very easily, but the radial fibers are not affected among those patients. The use of 3D echo and 4D echo can assess very clearly and very early the abnormality, especially if we use the 4D left ventricular quantification, can determine the classification of the heart failure to systolic and diastolic dysfunction, and can be very easy to assess objectively the predictive value, and can assess the predictive value of death and heart failure.
India studies show 36.5 to 53% of the population suffering from chronic stress, depression, anxiety. I submit that in general prevention work, and particularly once there is a CVD diagnosis, a stress screener must be included. Thank you.
Thank you very much. I think, Rick, you made a very important point. There is no doubt that there is a strong link between the mind and the heart, and there is a huge data to support what you're saying, and I think it is very well taken. Vijay?
Regarding the Roy's presentation was very good, but I would like to point out that it is not the reduction of alcohol, abstinence from the alcohol is very important, because alcohol is known to give rise to 20% of the hypertension and the cardiomyopathy and everything else, and then it is a depressant. So as he said that already depressed people, when they start taking alcohol, they are more depressed, so better not take alcohol. So the message should be no alcohol, no tobacco.
Vijay Lakshmi says we already depressed people, and with alcohol there is more depression. Ambuj, what's your opinion?
What is left in life?
Well,
Dr. Parashar says, third comment. He says, Rick says we are depressed people. Vijay Lakshmi says we are more depressed when we take an alcohol. And Dr. Parashar says, then what is there in life? Ambuj, please give a comment on all the three comments which you got from the audience. Ambuj.
The presenter.
Time is yours now.
I hope, I just wonder if there can be a no comment answer to this, but since you've been forced to this, answer this. I think you should, if you're having alcohol, don't bring in heart protection. If you want to enjoy your drink, go ahead and do it. I mean, if you want to do it, but don't say that you're doing it to protect your heart. Increasingly, evidence is showing that this is not cardioprotective, and as I said, we should not live in silos. Alcohol contributes to deaths through several other ways other than heart disease. It's linked to several cancers. We know it's linked to liver cancer, strongly linked to GI systems, and of course it's cause of deaths in India. So I am not in the position to comment on your evenings, how you should spend it, but you should not say that cardiovascular.
It's very important because Dr. Parasha, you know, he's an army person. And he was an army person, but he still continues to have some of the philosophy.
Thrombolytic therapy versus interventions. I didn't see any of the things. And you say, you have been saying that it is better, but then we didn't get any comparative figure, number one. Number two, about the diagnostic strategy. You mentioned about CT, MRI, and other thing. But in your All India Institute, next to your ICCU, you have a cardiac camera. So in our department in Mumbai, we have a cardiac camera. Suppose there is a patient of acute coronary syndrome, we inject in the ICCU and put the patient on the 24-minute study on a resting myocardial perfusion scan. It can give you size of the area, extent, ejection fraction, wall motion, one thickening. About 4 or 5 information in one sitting, which MRI or CT cannot give within a short span of 30-34 minutes. So there are two comments.
Yeah, thank you, Dr. Mahapatra. I think a very important slide was shown by Ambuj Roy, where he mentioned about tobacco-free legislation and 58% reduction of morbidity. It's enormous. I'll request Ambuj Roy to meet our health minister and to make sure at least we make Delhi smoke-free. What's your opinion, Ambuj?
Right, thank you, sir, for that comment. We already have a legislation. The point is we need to enforce it and bring better implementation. We know even in our hospitals, people just moving around and nobody says no to them. So the point is, yes, we need to very strongly implement these, and it has been clearly shown to have huge impact in several studies, and this was a small Helena Montana study which I quoted.
Yeah, Mr. Chairman, we have time for one last comment.
Last question, Dr. Vardhaj, last comment.
Sir, my question is to Dr. Ray, because as he said, he showed one slide that sometimes if alcohol is given, it is useful. I want to quote my own experience. I agree with Dr. Parashar that it should be advised in a very limited people. You must first assess the psychiatric assessment of the patient before you advise. Because I want to quote 2 examples. 45 years ago, when I advised to 2 patients, one was very young, he took the whole bottle, that my heart will be quite clean, and he died.
But we never advise. I tell you, the patients come and they ask, we say no. We never advise them that it is good for all them.